I just wanted to say welcome to the only workshop today looking at BDD in children and adolescents. And I'm really, really excited and honoured to have been asked to come here today and speak to you all. I'll just explain a bit about who I am, who we are, and why we were so excited to come here today. So I'm Laura Bowyer. I'm a clinical psychologist working in the National and Specialist OCD, BDD and related disorders clinic at the Maudsley Hospital in London. Bit of a mouthful. And we're actually the only clinic in the country that specialises in treating BDD in children and young people. My colleague Siobhan Kelly is also joining me in the front row. And I've just acknowledged our consultant psychiatrist and another colleague, Georgina Krebs, who are really at the front of looking at BDD treatment in children and young people. So you've heard today already, and lots of you know about BDD and how serious it is and the ramifications, and that it's a condition that's only just receiving sort of the much needed attention to raise awareness. And we think that's even more the case with children and young people. There's even less research, even less knowledge and awareness. So we think teenagers, young people with this condition are maybe even more isolated, more disconnected from people. And that's why, it's really exciting to be here today and get the message out there and to try and raise some awareness. So hopefully I'll be able to answer some questions, and really please do stop and ask questions as we go along. There's some familiar faces in the audience as well, so if there's things I've missed out and people want to comment on things and their experiences, that would be really good. I don't know if people feel comfortable, and only if you do, but just raising your hand if you're like a parent or carer. Okay. And a young person who thinks they might be suffering from BDD, or thinks they are. Okay. Brilliant. And then sort of professionals or people just here for interest. Cool, okay. So hopefully we can go some way to answering some questions. So really what I thought today was just a bit of a knowledge buster about BDD. I think we've talked a little bit that there's lots of myths and so forth out there about it, but really thinking if there's particular issues for children and young people when we're talking about body dysmorphic disorder. Then really thinking about treatment of BDD, so to give you guys a chance to find out what the treatment looks like for children and young people, where to get help from, and a little bit about how it works and what to expect. So just a little bit of a kind of knowledge buster, I guess. Like I said, there's lots of myths out there on the internet about BDD. This is to maybe debunk some of those. And these are things that we've put together from what children and young people come to treatment asking and believing. So these have come from the kind of concerns people come to treatment with. So Siobhan's going to help me out on this a bit with a bit of a hand raise for true and false. So I'll hand over to you.
So I know that Catherine covered some of these things this morning, but we just wanted to get an idea, and just if people could raise their hand as I go through the statements, if you think it's true or it's false. So the first one is, it's normal to worry about how you look, especially as a teenager. Do you think that's true? Yeah. Anybody think that's false? Okay. About 2% of adults, that's 2 in every 100 that you meet, have BDD. Do you say that's true? BDD is about being vain or self-conceited. Does anybody think that's true or false? False. These worries cause lots of distress and interference in people's lives. Say that's true. And these worries cause problems with family relationships, attending school or college, being with friends and playing sports. Most people report that the start of their appearance worries start in adolescence. And individuals with BDD are striving for perfection with their appearance. People think that's true? It depends. It depends on the individual. False, yeah. Does everyone think that's false? Okay. That's one to explore. BDD is far more common in girls than boys. Do you believe that's true? Okay. And many teenagers with BDD also say they feel depressed or suicidal. Do you say that's true? Yeah.
This is what comes at doing the workshop. At the end of the day, you've had all the information. It's great, 100% we expect. So we'll come back to those after sort of talking a bit. So I guess when, people come into the clinic or we see young people with BDD, it's kind of a label, but it's a bit of a mouthful, isn't it? Which is why we shorten it to BDD. And just kind of thinking, well, what does that actually mean when we use that kind of label? So I guess, as you've heard lots today, it's a psychological disorder, which is really just thinking about more how we're feeling internally, our confidence about ourselves and how we're feeling on the inside, that causes young people to become really distressed about these perceived body defects to the point it gets in the way of their life. We've underlined this word very for distressed, and I don't think that's news to anybody here after what we've heard today. But also this word perceived, because I think also that can be hard to get your head around. And really all we're talking about when we say that is how we kind of see things through our eyes, the perspective, how we look at things. And I guess just thinking about how that works. So we've got a couple of pictures at the bottom here. So I don't know if people just want to shout out, do you see a vase or a pair of faces? Faces, vase, yeah. Hands up those who see the vase. Okay. You see what?
I see it's a chalice, not a vase.
A chalice. Oh, okay, new one. Yeah. And those that see the vase, can you see the faces now?
Yes.
Yeah? Okay. What about this on the right? Old lady or young woman? So who sees the young woman? Yeah, can you see the old lady? No? So it's a bit of a tricky one. So the young lady is looking like she's looking to the right-hand side, and this is like a choker across her neck. And she's got like a hat with a big veil and a feather sticking out of her hat. And this is like a choker in her jawline and her eye. Like that? Don't know. And the old lady this is kind of like, almost like a fringe, a hat, 2 eyes, and a sort of big nose. And then her mouth with a hooked chin. See it differently now? It's always a bit. I don't know if people have seen this or saw it in the papers, so let's have a bit of a... I don't believe this and I haven't done it, so I'm really worried this is going to epically fail, but hands up if you think that's blue and black. Ooh, see? Anyone see it as white and gold? Brilliant! Thank you for saving me. I had fears that everyone was going to say blue and black. So white and gold. And you completely see white and gold?
On the internet I saw white and gold, but now I can see it as well.
You see it as beige? I did have someone say gold and blue, which was the first person that did a mixture, which I wondered. Can you see the blue and black?
A little, not the black.
You're not convinced?
The white can be kind of mistaken for light blue, I guess.
Yeah. One to try on your friends, maybe. I mean, people that see it as white and gold say it's literally as white as a wedding dress white, which to me, I mean, I'm seeing blue and black, like most of the people here. So it is actually blue and black. That was the design of the dress. But we just kind of think these are ways to sort of think about this idea of perception. It's interesting that we can't all be right. We're all seeing something different. And interesting that even though the pictures haven't changed, we're all seeing something different and can switch between seeing faces and a vase there depending on that perspective. So I guess it's just thinking that perception, how we view things, including our appearance, is complicated. It's not as straightforward as just seeing a single image and that being the same for everybody. And just thinking how that might lead to the development of some of the concerns that we see in something like BDD. Maybe things aren't as fixed or as certain as we might have first believed. Have to see how convinced the white and gold people are that that could be blue and black. So, a bit about BDD in children and young people. This has been talked about before, but to give you a bit of an idea about how this looks, I guess, in children and young people. We know it's got 2 parts, really intrusive, repetitive thoughts or images that have been described as really intrusive. So you don't want them, they're unwelcome, they're really popping in all the time when you don't want them to. So some examples from young people we've worked with who describe it far better than I can. So I have to do my hair every morning until it looks right. This means washing, straightening, styling, and then often starting again if it doesn't turn out okay. Usually I don't get into school until lunchtime. I just feel ugly. My face doesn't go together properly, my nose is too big, my eyes are too small, and my forehead's too wide, and I hate looking in the mirror. I've always hated my chin. I think it's too big and juts out too far. It's humiliating because I feel that everyone notices how big it is, and I feel like a walking chin sometimes. And I really don't like my hands. They're too big and masculine looking. I wear gloves wherever possible and keep them in my lap at times during school. I'm always comparing my hands to the girls in my class. I feel like my hands are disgusting compared to theirs. And I think I'd cry if I had to write on the board in front of everybody. So do they sound, I know you've got lots of parents and carers rather than necessarily young people, but do they sound sort of familiar in terms of content and how that manifests? And I think just to say in children and young people, and Kathy talked about sort of young people as young as 6, and certainly in the clinic I work in, we've seen down to sort of 11, 12 with these kind of concerns, is literally anywhere on the body. Talked about face being more prominent, but just to say all concerns go from your head right down to your feet, including concerns about genitalia and so forth, your boobs, things like that, just as common in children and young people. So important to have those conversations and kind of allow, I guess, young people to talk about these concerns, that they're, not vain and not just being self-conceited. We know that these thoughts make people feel really, really embarrassed and disgusted, and as we've talked about a lot already, kind of different compulsions that people do. So these are just some of the ones for children and young people. Washing and cleaning routines, so buying lots and lots of products, lotions, potions and scrubs to try and correct things. That might often be if you haven't got money. As a younger person, it might be sort of creating your own potions with things that could be quite dangerous, using bleach, for example, lemon juice and acid and stuff to try and clean your skin. Checking in the mirror, don't think that's a surprise to anybody, and getting stuck in those routines. And checking physically, so lots of sort of touching of bodies and checking various parts of your body physically. Talked about muscle dysmorphia a lot today. And again, we do see that in children and young people, not as common. We do. Wanting surgery? How many people feel like people that they know or young people themselves sort of want surgery? Stick your hands right up. Yeah. So we'll talk a bit about some of that and the impact of that. But certainly we did a recent treatment trial within our clinic, which we believe is the first in the world to look at this treatment in children and young people. And certainly nearly half of the young people that we saw were desiring surgery or had booked a consultation with a surgeon. And we've met people that have had surgery as well. And that's as young as 12. I think sometimes there's a myth that to do with adults or no surgeon would operate on a child. It happens and we do see it, which is really, really scary. But as young as 12, sort of being offered an operation on the NHS. Pictures. So I guess this is across the board, but I think particularly with children and young people, the role of kind of now smartphones everywhere, cameras, access to media, which I'll talk about in a minute, so constant opportunities to take selfies and check things out. Avoiding relationships, intimacy, sex, for example, or avoiding mirrors, just hanging out with your friends, going to school. I think this is a really big thing that we've seen in the clinic. So lots of seeking reassurance, maybe from parents and carers, sort of two types. One kind of trying to get sort of reassurance, do I look okay? But another type trying to get sort of validation, so can't you see that mark on my face? Can't you see how ugly I am? I'm really wanting that confirmed. But also, these are out of date and I don't pretend to be up to date. Facebook, I think, is really old news now, and there's a range of other social media sites out there. But kind of reassurance can be done through websites. There's this one, Hot or Not. that are out there looking at uploading sort of pictures of yourself to get rated on your appearance. And I think the problem is a lot of these have been designed for adults over 18. So we've got a problem with, I guess, young females, males as well, uploading potentially quite revealing pictures of themselves to get reassurance on websites that are being accessed by much older people and leaving them very, very vulnerable to risks. Talked a bit about mental rituals. So these are things typically done in one's mind to, again, try and get rid of those horrible feelings that come with those thoughts. Comparing to, might be celebrities, but more often than not, it's your peer groups, other people in your class, people on the street and so forth. And lots of other things that we've talked about today, sort of ruminating, so going over past events. So coming home from school maybe, sitting there replaying a conversation over and over in your head to try and remember, how did that person look at me, and did they look a bit disgusted, or when that person laughed at me, it must have been because I was so hideous. There's also other things that we've talked about in terms of skin picking. And they typically take up many, many hours of the day, as Kathy talked about earlier, and they're often quite hidden. So often parents and carers say they don't notice these behaviours for a while. It's kind of quite typical maybe for an adolescent child to go upstairs and they get home, shut themselves in their bedroom. You assume, they're kind of interacting on the media or whatever, and actually might be sort of spending hours in these kind of vicious cycles, sort of attacking themselves or getting toxic feedback from media sites, or kind of getting stuck checking in the mirror. And the last one up there, camouflaging. So just to say as well, with makeup and stuff, just as much we see it in males as females, and I think that's reflecting generally. I was at a talk earlier that Simon was doing, saying that he'd never used moisturiser and has now started to use it, and it's just become a bit more of a normal thing for males to be self-grooming, but certainly we see then sort of use of makeup and stuff in males to hide those appearance flaws. Any questions up till there? Please do interrupt and ask. No? Cool. So just thinking a bit about the impact for children and young people. I guess we know that BDD can cause people to avoid people and places. But I guess for children and young people, really thinking about the impact of school. This is an age where you're getting lots and lots of experience socialising with peer groups, developing friendships, doing exams. So lots of, your social network, education, your brain is growing and developing. And to be out of, that world and disconnected from it means that, you're losing out on a lot of things potentially. And I don't know, again, here if parents have had that experience, or carers, or young people themselves, of getting told off at school for not concentrating or having to leave lessons. Yeah, some nods. So even when you're at school, you're trying to concentrate in a lesson and you've got these thoughts going round and round and round in your head. You can't concentrate on what's going on. And we meet lots of children that are told off for kind of being naughty, disruptive in the lesson. Or you get an urge to go and check your appearance and you can't wait. You need to get up and leave the lesson to go and check in the mirror. That will often result in getting a detention and being forced to go into certain places which are more anxiety provoking. So we do lots and lots of work with schools to help them understand about BDD and mental health generally, I think. But again, in the clinic, when we did a recent trial looking at this treatment in young people, over 50% of the children we saw were either not attending school or completely out of school or housebound. So it's a really serious issue, and it's not any less severe than what we see in adults. Just to give you an example, I'll never forget, actually we did an assessment with somebody that was so poorly, they were stuck at home, and actually had got to the point where they would wear a towel over their head. Even sort of interacting with their family members was too difficult. And lots of people sort of report that. Pleased to say that person is now back at school, but it really has profound impact. In terms of family members, I think, again, we see this in adults, but I think particularly with children and young people, This can be massive impact, and this is what families sort of tell us financially in terms of buying products and lotions and potions. Young people might not have access to that money themselves or jobs. Surgery, we've talked about. We've met many parents that, although intuitively kind of feel that surgery is wrong, can be really understandable after sort of years of not getting help or years of sort of somebody saying, this is the answer, this will just make me feel better, that, you know, that has happened, and sort of paying out thousands of pounds for surgery in a desperate attempt really to try and alleviate their child's distress. Missing work to look after their child, and nods in the audience there, and having to be a carer. Reassurance seeking and arguments. I think we heard a bit about this before, but just lots and lots of families getting, I guess, drawn into those discussions about somebody's appearance, and that frustration that can happen because of the differences of perception, and the stress around that can be really difficult. Sort of desperately wanting to tell your child, but, you know, I can't see anything wrong, I don't understand. And obviously the young person feeling completely misunderstood and saying, you know, you're just lying to me, basically. You're my parents, you love me, of course you're going to say that, but you're lying. And that can obviously lead to lots of tensions. And we just know in children and young people, when someone's really distressed, that can come out in maybe more aggression and frustration, in sort of younger children as well. So we can have sort of quite severe arguments and highly distressing situations for families at home to deal with and manage. So that can be really, really tricky. So we talked about feeling low and depressed, generally in BDD, and self-harm and suicidality. And I've talked a little bit also around the risks around media and uploading photos and so forth. But how much of an issue do we think it is in children and young people? So what kind of percentage do people think are kind of either self-harming or really considering suicide? Shout out some percentages. What do we think it is in children and young people? Maybe raise your hands as I go through, sort of like 20%, 30% of young people, 40, 50, 60, 70? Okay, so most of you say it's sort of saying around 50%. Again, this is both either. In the, again, the trial we did, so obviously it was smaller numbers, it was within 30 young people, so we've got to be careful not to generalise this too far out.
So just to ask a question, it says avoidance of relationships and dating.
Yeah.
Did it also show up as promiscuity?
Thank you, that's a really good point.
Like maybe both extremes.
That's a really helpful point, actually. Yes, it could. Sort of attending parties and drinking a lot to be able to cope with that, to get validation. And again, this is sort of anecdotally, so it's not, but as you know, as a clinic, we've been working with OCD for many, many, many years, and more recently with BDD, and the number of pregnancies that we've seen in young people with BDD is, you know, we've had that occurring. We've never seen that in a case of OCD in the whole history the clinic's been running. So, yeah, there's something potentially really vulnerable when you're feeling really low about yourself, low self-esteem, to maybe want to attend these social events desperately, everyone else is going, to drink alcohol to cope with that, then of course your inhibitions are lowered.
And also I was just wondering, if you have such a hatred or a disregard for your own body, you might let others violate you. Or,
Yeah.
You know, you just might not care. You know, that's why I was thinking about being more promiscuous.
Yeah.
And they may not even know they're doing it.
Yeah.
Your minds are so young, you don't even know.
Absolutely, and it's not, I think, because I've forgotten which speaker it was, but it's not like this is a conscious, it was again Simon's talking about sort of skin picking, and actually sort of, you know, it's not a conscious thing when you're going out and plan that you know, want to be taken advantage of in that way, but maybe getting carried along and really then all the shame and disgust that can come after that, and really kind of beating yourself up for that, definitely. So yeah, not to take these figures and apply them everywhere, because this just comes from a really quite small study, but over 60% that we saw in our clinic as part of this. So it was nearly 50% had self-harmed and 24% was suicidal. Again, in recent treatment trial, you know, we did have people that attempted overdoses as well, multiple people. So again, we kind of thought that maybe, in children and young people, we'd catch things earlier, and I think generally what we're finding is it's not being picked up and detected as early as we would like. So this is the severe end of the group, so just to say that. But I think, maybe it's a product of it not being picked up in children, being seen as kind of typical developmental worries. And lots and lots of parents can really beat themselves up by the time children are seen at our clinic, for example. And I think just to say that this is a very covert disorder. It's not that easy to see the symptoms. And the symptoms can really mimic very typical childhood development. You catch your son or daughter looking in the mirror and you don't think that much about it. So it really is emphasising, this is a horrible disorder and it's no one's fault. It's not parents' fault or the young person's fault. But we definitely, part of today is increasing that awareness so it's picked up earlier and earlier so people are seen before it gets to sort of such horrible levels. So, any questions, other questions?
Yeah, even if you detect it early, we detected hard ones a year ago, it still takes a year to get to the right treatment.
Yeah.
A minimum.
Yeah. We're going to come on to treatment, I think that's unfortunately a bit of a reality, but we're going to talk about then how to help you with that process so you know where to be going, what to be asking and what to be looking for to helpfully speed that up. So hopefully you should all know the answer to this as well. How many people do you think, children and young people, experience BDD in the population? Percentage?
2%.
Yeah. So just to make my maths easy, if you've got a school with 1,000 people, because I can't do any other maths, that's up to 20 people. So I think it's just worth thinking that and taking that back home if your children aren't here, or if you're thinking about that there's probably like up to 19 other people in your school that have similar appearance concerns or are worrying about how they look. Yeah.
Can I just say, I have BDD, and of the people, because I've been quite vocal about it on social media, people that have spoken to me, contacted me from my school, just from my year group, at least 8 people in my year group out of 300 people have BDD.
Wow. Wow, that's really helpful. And I think this 1 to 2%, to stress, that's come from adult studies. Looking back at when this started, we don't have the information for children and young people. So I wonder, could it be more than that? So that's really helpful. Yes, there's more questions.
Were you born with BDD?
No. So we think it's a bit of... We don't entirely know. We've got a slide on that I might come to, but the short answer is it's a bit of a mixture of things, probably genetic component, but also experiences, bullying and teasing. But we know it's not that straightforward because not everyone that's been bullied or teased ends up with BDD. Not everybody that's got a massive family history, say, of anxiety disorders ends up with it. So it's likely to be a bit of an unfortunate culmination of lots of different things coming together, and then maybe a bit of a stressor, changing schools, going to secondary school or something. Yes.
Is it possible that society now is more BDD inducing for young people than it ever was?
I think it's something that comes up a lot, and I think we need to be a bit careful because I think there is an increased role of the media and things, like we said, access to social media sites and the role that plays. But again, we know not everyone that's got access to those ends up with developing these kind of disorders or conditions.
So is it prevalent in other parts of the world, or is it mostly Western?
We need better. We don't have good studies looking cross-culturally at things. I think there's something quite interesting about London, for example. You've got a real mix. David Veal's been talking a lot about feeling different. So if you're a different ethnicity and you've got such a mix of people, say, in London, I think, there might be potential to feel more different or at odds than in other contexts, which might just contribute to those feelings.
I just want to, I have read a study, I can't remember what the source was, but they did do a study, I'm sure it was completely conclusive, but it was assessing the prevalence of BDD amongst different cultures and different parts of the world, and it was about the same no matter where you looked in the world. So it seems like it's not just a cultural thing. There are a certain amount of people that seem to be predisposed for whatever reason.
Yeah.
Maybe.
No, thank you. To be clear, it's certainly something that we see in other countries as well. Yeah, absolutely. So, would you know who those people were in your school? shaking heads. Yes? How would you know?
The sort of, when they're conversing, so my child is 17, but he's got older brothers, and amongst their friends, you can see the ones that have gone from, going to the pub every night, suddenly becoming physical trainers, the way their diet changes, the way they're constantly reading books about which would seem to be about healthy eating, but actually their personality has changed quite a lot. And so therefore they're slightly older than at school. Well, immature 20-year-olds.
So you might notice in terms of if you knew that person and had tracked them and see changes in their behaviours, definitely. But I guess usually what people say is actually if we lined up all the people in your school that you didn't know, could you pick out the ones that had these appearance concerns? Like for you, did you know who those 8 people were in your class?
Only one of them because she told me.
Okay.
At the time.
And I think that just hopefully gives more idea to this idea that it's more of a problem with how you're feeling inside rather than actually people being able to notice that on the outside. I'm going to jump on if that's okay because I just want to make sure we've got enough time for speaking at the end. You got all of these. Right, so to me, the one that I think about this perfection came up as a bit mixed. So I think sometimes there's a misconception that individuals with BDD want to be like the models and perfect. And actually, typically what we see is young people just saying, I feel so far below just average, I just want to look average, just normal would do. So not striving for that sort of perfectionistic look or kind of like the models in the magazine.
Sorry, has there been any research on that? Because certainly one young person I worked with, it was absolutely about being perfect.
Yeah.
And they stressed that.
Yeah, absolutely. There's always going to be, these aren't sort of catch-alls for everybody. These are sort of more the general presentation. And certainly things like muscle dysmorphia, you might get that, you're talking about bodybuilders or athletes in the top X% of the population anyway that are training that hard. So obviously if you're trying to be comparing with those kind of body types, you're going to be up at that end. So generally speaking though, it's really not about that. It's just wanting to look normal. But I think everything else you are up on. So I want to make sure we talk a bit about treatment for children and young people. You've heard about CBT lots today, so cognitive behaviour therapy. And I guess why we think that's a good fit for BDD is just literally that cognitive is a posh word for our thoughts, how we think about things. Behaviour is our behaviour. And as we've just learnt, young people that suffer from this got lots and lots of horrible thoughts about their appearance, and it affects what they do. So that's why we think it's a good fit. We've heard from Kathy and David and others today about this treatment with adults. But they're, even though it's not well developed, it's much further ahead than child treatment. So the recent trial that we did in the clinic was the first in the world looking at measuring that in any kind of systematic way to see, does it work, is it an effective treatment? And certainly we know it is, but it's not getting everyone better. So there's lots and lots of scope for improvement. And compared to OCD treatment that we've been developing for many, many more years, we know that there's much higher kind of success rates. So we're really excited about doing lots more with lots of young people with this condition. But really exciting that we've got this and developing it. And something I'll talk about at the end is actually we've got a workshop for professionals, if there's any here, that we're going to do in November, which is going to be rolling out that treatment, so actually disseminating that treatment to professionals to say this is what we've learnt from what we've done so far. Here it is, please go and try it, please go and use it with patients around the country. So I've got some information for that.
That's CBT treatment.
Yeah. So come and please get a flyer and send it around your services. It's important that this is done by as many people as possible. Medication as well, you've heard talked about, but again, with children and adolescents, there's not as much evidence base at all, but it's something that we know is effective. Certainly for OCD, there's a lot of more evidence behind it. But as Kathy was talking as well, really important to be doing this at an adequate dose. So very typically we see lots of young people, if they have been put on medication, quite a low dose and not for a long enough period. So, for example, with sertraline, these are the two that are licensed for children in the UK. But certainly, typically, the children in the clinic we see would be up to 200 milligrams of sertraline. And on that dose for sort of 2 or 3 months before we'd be making that decision whether that was helpful or not. So there's definitely a role probably for both together. Lots of families have lots of reservations and understandable questions about that. And I think getting that information and I guess like Kathy was saying, knowing that and then making an informed decision is the kind of best way forward. So just to say about what CBT for children and adolescents, so when you go for that, what should you be asking for, what should you be expecting? So we offer up to 20 weekly sessions. I think that's one of the things we learned from our treatment trial, that you need more sessions than maybe for other disorders, anxiety conditions. Family being involved in sessions. So I don't know here, out of the carers, how many of your children have had CBT before in the past? Yeah? And how many was it successful? Half, yeah. It's generally... In the end, yes. But I think that's really important. I think CBT is a bit like when we say medication now. So when you say I take medication, it could mean 100 different medications. CBT now is such a big therapy and is used for so many disorders. It's kind of an umbrella term. And we think there's lots of different components of CBT that are really specific for appearance concerns and BDD that you wouldn't use in other disorders. So it's really, really important. I'm sure some of you went to the advocate talk maybe before this. It's really important that you're getting treatment that is CBT specifically for BDD, rather than sort of generic CBT for anxiety. And we do think it's important family are involved in sessions. And parents got a really big role in treatment. They're not only affected, and family life is massively affected by this condition, but also a role to help everyone try things in a different way and not leave the young person just on their own fighting this. It's really tough, I think, for families to be involved, to see their child maybe distressed and facing situations without that support there for themselves to help them do that. So we think that's really important. Family are involved in that, learning lots about this condition and taking an active part in treatment. So what does it typically involve? So we think there's lots of learning, first of all, so becoming a bit of an expert in this before we jump in and start changing anything. So learning lots about appearance concerns, body dysmorphic disorder itself, and anxiety. Thinking about lots of situations the young person finds difficult or challenging and the kind of thoughts and behaviours that get in the way of those. And then really importantly, it's learning ways to help with that distress, to help with some of those thoughts before you kind of then start gradually kind of facing those situations and approaching them with lots of support. So that's the really key thing to say. It's done in a very graded way with lots of support, and you're not kind of thrown in the deep end. And as Kathy was saying earlier, it's very much a collaboration between you and your therapist to work that out together and take that in steps that are manageable. And I guess the key thing to just say is young people who have CBT and or medication, not all are on medication, they can and do get better. So I think that's the key thing we wanted to say, even there's a bit of persistence needed and sort of a trial of CBT, sort of really thinking about sort of how that was delivered, were family involved in the sessions, do you feel like things were broken down enough for you, and if not, to persist and try again, because I think it's really important.
Hi.
Hi.
Is CBT the only thing on offer? It seems to be the only thing that is on offer for everything from drug addiction to psychosis. I mean, can you not? And it doesn't. If the subject is, has got voices in their heads, or they're particularly anxious or whatever, they can cut most of the chat out. I mean, it is talking therapy. They don't listen to it. Is it really the only? Is it the best you can do?
Good question. I can't comment about other disorders. For body dysmorphic disorder, it's the only treatment that's got any evidence base. So, like we said, we're not saying it works for everybody. But actually, that's the important thing about it, is it's not just a talking therapy. Should really have emphasised that, actually. So the behaviour part of things, and really about them doing things differently and approaching situations. So that's another thing to watch out for. You shouldn't be in the room each week with your therapist just talking. Yeah.
I think another thing is that CBT will only work if you're really committed to it.
Yeah.
That's what I realised, that if you're not remitting and you're not ready and you're not wanting, or not that you don't want to, but if you're not really putting everything you have into it, it just doesn't work.
Thank you. That's a really helpful point, and glad that you said it's not about not wanting to. It's recognising that this is hard, this isn't easy. This is like facing your most scary situation in a sort of a graded way. So absolutely, there is about the right time and right place. But then when you do that, to make sure you're getting good quality, I guess, intervention. Yeah.
Well, it's just I'm an EMDR practitioner, and I felt a bit taken aback because when I asked a question with Simon before, I was just told it didn't work at all. Does NICE recommend CBT for children particularly? I mean, there is an evidence, so NICE is saying this is an evidence base for children.
It's part of expert consensus, because you got to realise that our trial was one of the first ones to look at evidence. But for example, EMDR is an evidence-based treatment for other conditions like PTSD and in children, but it's not recommended currently for BDD.
And that's probably because that haven't been the research, and possibly because it is more covert and it hasn't come up, it hasn't hit the screen. But I've used it a bit with young people, and given I work in a very short-term service, fairly successfully, at times successfully, not with everybody. But you've said everybody needs to be thinking about what's going to help. You know, whether there are, and obviously EMDR is not just a talking therapy by any means. So I just want to say, you know, in answer to your question, that hopefully there will be a sort of open environment for other approaches to be tried out, because there's enough suffering out there for that.
What are the reasonable options in that case, other than CBT?
Well, I was just saying that something I'm a practitioner, it's eye movement desensitization and reprocessing, horrible technique, but it's the main evidence base is when there's been post-traumatic stress, and there does appear to be a connection with body dysmorphia and having been triggered by a very traumatic bullying or teasing or some comment that has actually been very traumatic, and that's a very clear indicator for it being a useful approach.
I think just to make sure we give enough time to our speaker as well, just to be really clear, I think there's a trauma element to BDD definitely, but PTSD is a very different and completely distinct disorder from BDD. And the reasons that we kind of do these diagnoses and do this is because it can then signpost us to the best available treatments. I think this field will emerge, there will be developments, but I think, you know, when we're treating especially vulnerable children and young people, we've got to do what at least we've got some evidence for first, and do that well before we start kind of adding in other things. So, just to say in terms of getting help and how that will kind of work, so typically people first go to their GP and check and review mental health, and usually get a referral to their CAMS, Community Adolescent and Mental Health teams. And these are teams locally, so geographically, they'll be near to you. And therapists are trained in a range of different treatments, but usually CBT, and so it can be a really good first place to think about getting CBT for BDD locally. If that doesn't work, or indeed your local service feels that they haven't got the expertise to do that, then a referral to our service would be considered and appropriate. So I'm not sure of your story at the back there, but you don't...
BDD can only be treated in adolescents in Maudsley. It can't be treated like that.
You don't think so?
CAMS is just a failed severity.
I think I don't want to wipe out the whole CAMS service in the country. There are some fantastic services, and there's some brilliant practitioners that. So I'm not. There are some fantastic clinicians working out there, and you've got to remember we're in an extremely privileged position working with this disorder day in and day out. Whereas other services are working with all of these different disorders. Nonetheless, if they don't have the expertise and you don't feel that you're more than entitled to ask for that second opinion. And you've had the advocacy talk, so I won't go into that now because I want to make sure we leave enough time for our young person to speak. But just to say, I've brought some leaflets about who we are, so you can take those away, and I just really use the information you've had from that talk to ask for second opinions, to get a referral if you don't feel you're getting that access to treatment locally. But I think that accurate diagnosis and just finding out actually this is BDD going on is a real first step to getting that.
What's the waiting time at the Maudsley then?
At the moment, so we aim to offer an assessment within 12 weeks. It's usually earlier than that. Waiting times vary. Sometimes it's as little as 8 weeks. If we've got people leaving and coming in and out of the clinic, as we do at the moment, it can be longer, up to sort of 4 or 5 months.
You are the outpatient, not the residential.
Absolutely. So we're outpatient service. So above this, you would have inpatient and hospitalisation. If young people are working with us and things deteriorate, then we can help facilitate that admission and maybe work alongside them. But no, we are generally an outpatient service. Yes, question that was waiting patiently.
Yeah, sorry, just to commend the Maudsley for all the work they do, because they're such an amazing service, and it is there. And on your point about the CBT being the only thing, what people are trying to do is get a more individualised service, so people can actually look at the therapies there and actually make CBT more individualised, so it can help a person, not just as just a number or make it more individualised. And I think Maudsley are fantastic at what they do. And although people seem to not like hands, blame Jeremy Hunt.
Yeah.
No,
but thank you.
With your child, you want to be, when you do your research, you want to go to the best place, the best people instantly. You don't want to be batting around.
Of course.
Once you do a bit of research, if you've got a bike and bang your head, you want to go to the Queen's Medical Centre. You don't want to go to the library, do you? You want the top people looking after your child.
No, even if your child has severe body disorder at the age of 11, you don't want to only have access to a social worker for 3 months. Who misdiagnoses your child and tells you their phobias and their avoidances of control issues, and they advise you to drag him to school kicking and screaming because he's terrified, and then tell you that all their therapists have left and you go back in the system for 4 months and you're left with nothing again.
Completely.
And then they refuse to refer you to the Maudsley time and time again. I got refused as well. I was suicidal and I got refused.
Yeah. So I'm just gonna.
And even worse, no correspondence whatsoever from any department anyway.
Yeah. I'm just gonna pause this because I think no. But I want to make sure we've got time for our young person to speak, because I don't think, unfortunately, the experiences here are unusual. And it's an imperfect world, and I guess part of coming here today is to try and give that information to you to know where, to go, that there are these services there, and it is a fight. And I know that's been talked about. We, had to give a whole talk to that on its own because of that reason. So it's not perfect, and, individually and as a team, it'd be great if this was being done more, but this is sort of what we're about, disseminating this and trying to get people trained up and do this. So hopefully that's what we can move towards. And if not, we're here, you can take a leaflet away and really fight, and sometimes it is a fight, but young people that do get seen and have good treatment do recover from it. It is common, and they can kind of move forward and have a normal life.